Hey, good evening, everyone, and welcome. It's great to have such a good turnout for this meeting tonight. A nice multidisciplinary team coming together, not only to present, but to actually be a part of it as well. So thank you for being here for the antenatal quick update with some great new information about fetal blood group testing for rhesus negative pregnant people. And we're being hosted tonight by CHN. Thank you for that support and assistance. Make sure I'm getting my slides changing properly. It's not, of course, it's not working. This is what we were just talking about before we started. There we go. Before we begin, I would like to acknowledge the Ngunnawal people, the traditional custodians of the land on which we're meeting tonight, and any other people or families who have connections to this land. I pay my respects to their elders, past, present, and emerging, as well as to any Aboriginal and Torres Strait Islander people here with us tonight. So I'm Dr. Melanie Dorrington. I am the Chief GP and Primary Care Advisor for ACT Health. We will soon be the Health and Community Services Directorate, just in case you start hearing that one around the place after July. And we are joined by two presenters from CHS, Dr. Farah and before we get going, a couple of bits of housekeeping. Can everyone please keep yourself mute? Oh no, you've all been muted on entry. You won't be able to actually literally ask questions, but there is the Q&A box for any questions coming through. Please don't use the chat box for that, but the Q&A one. Chat box can be used for general discussion if you want to. We will have a Q&A session at the end of the presentation, so any questions you ask will be answered at that point. And slides and resources will be sent out at the end of this. And the video, this is being recorded. This will be available on the CHN website if you want to come back and have a look at it. And any certificates for attending and the evaluation surveys will be distributed after the session. Now, there is going to be some new information presented tonight. And as a part of that, just so you know, we are going to be supporting that by having it available on Health Pathways. So this is for anyone who hasn't seen the antenatal routine, antenatal care routine pathway. This is the information that is available on it. So you can see that we have a bit at the top about syphilis and RSV that we haven't updated recently. And the more exciting bits will come down the bottom. The amazing Health Pathways team have been working hard on getting this up, but it is still in draft mode. I need to switch this slide again. And so on the draft website soon, after it's been through all its approval, this will be on the live site where you'll see that we have the information that we will be sharing tonight about the fetal blood group testing, so that we can all have that to refer to, knowing that it's a really important thing, but actually we don't necessarily see it that often. So we need a good resource that we can trust. So that will soon be up on Health Pathways. I am now going to stop sharing so that I can hand over first to Dr. Farah Sethna. So we're going to be covering recent updates in pregnancy care for 2025, as well as that fetal blood group testing, as I said before. So Farah will start, and then Dr. Phil Crispin will follow on. Thanks, Farah.
Can I just confirm you can see my slides and hear me?
Yep.
Perfect. Okay, good evening, everyone. Thank you very much for the welcome. So this evening, I hope over the next sort of 35 minutes to make a whistle-stop tour over what's new in antenatal care. So I hope, and this may be rather ambitious, that we will spend a few minutes talking about reproductive carrier screening and some of the issues that are becoming apparent when speaking to families. Try and demystify screening for early pre-eclampsia. Think about screening and risk stratification for spontaneous preterm birth screening. Talk about what's changed within syphilis testing during pregnancy. mention measles, given that we are experiencing an outbreak in Australia, talk about new vaccinations, remind you about cervical screening before Dr. Crispin takes over and tells you all about what's new with rhesus D NIPT. Okay, so to begin with reproductive carrier screening. Just to remind you, the reason this is important is this is screening aimed to identify whether one or both parents are carriers of specific genetic conditions and therefore enabling them to determine their chance of having an affected child. Couples who are found to have an increased chance of having a child with a genetic condition can therefore then make an informed decision about their reproductive options. We have the option, depending on who the provider of your assay is, to perform this test either via a blood sample or a saliva sample. And ideally, testing should be performed prior to pregnancy or at least in early pregnancy in order for parents to be able to make these decisions. There are two main ways of testing. There's firstly a 3-gene carrier screening panel, which comprises of testing for cystic fibrosis, the most common life-limiting autosomal recessive condition in Australia. We've got spinal muscular atrophy, which is a genetic cause of infant mortality, and finally Fragile X, which is associated with intellectual disability. For the 3-gene carrier screen, this is covered by a Medicare rebate for the reproductive woman, but only once in her lifetime. And I do want to stress only once in her lifetime, because if inadvertently the woman gets screened for a second time, she will get handed a bill by Medicare. So it's really important to check if she's been screened, where she's been screened, and actually obtain that result. In the 3-gene carrier screening, it's sequential screening. So the female partner is tested first. And if she is found to be a carrier for either cystic fibrosis or spinal muscular atrophy, her male reproductive partner is then tested. And there is a Medicare rebate for that testing. If at any point the woman has a new relationship and a new partner, and she is a carrier, that partner can also be tested under Medicare. The other option is testing for an expanding large panel testing, and you can test from anything from 100 genes up to over 1,000 different genes. This panel will also contain the 3 genes we've already talked about. Most of the conditions tested in these panels are rare, but they are important childhood onset conditions, which is why the testing forms part of these panels. There is no Medicare rebate for this test. So what will parents do with this information? Sorry, I've lost my mouse here, apologies. So parents then obviously, nothing's moving, have an opportunity to make some decisions about their reproductive options. Some parents will choose to still conceive spontaneously, continue a pregnancy without any extra testing. For other parents, it's very important to have the opportunity to have prenatal testing, and that may either be in the form of relieving anxiety if they found out their pregnancy is unaffected, or indeed if they found their pregnancy is affected by the condition, it gives them an opportunity of either having a conversation about what care for their child would look like, given we have had some technological breakthroughs in management of cystic fibrosis and spinal muscular atrophy, or indeed potentially making the choice to end the pregnancy. Other couples will use the information and decide to conceive with IVF and will either choose to screen embryos and only transfer unaffected embryos, and others may still choose to use donor gametes. One question that I don't infrequently get asked is, I don't have any diseases in my family. Does that mean I don't need carrier screening? And it's really important to realise that a negative family history does not decrease a couple's chance of having a child with a genetic condition. In fact, 90% of carriers in Australia are found to have no family history. And as individuals, we all carry about 2 or 3 recessive disease causing genes by chance. If we think of just the 3 gene carrier screening panel, I find these numbers useful to have in my mind. 1 in 20 individuals who are screened will find that they are a carrier for at least one of these 3 conditions. 1 in 240 couples will find they are both carriers for the same autosomal recessive disease, or indeed the female is a carrier for Fragile X. And about 1 in 1,000 pregnancies will have an affected pregnancy. Clearly, the more conditions you screen for by using larger panel testing, the more likely you are to be found to be a carrier for a condition. And in fact, if you look at large panel testing, 1 in 44 couples will be found to be both carriers for the same autosomal recessive disease. I've included this chart that you can reference later. It just gives you a summary of the clinical and genetic features of the 3 conditions we screen for and help you answer some of the questions you may get asked. What about the other option? And I have a healthy child, this means I don't need carrier screening. And again, this question often reveals the lack of health literacy sometimes in the community. And I find in this situation, getting out some pictures very, very helpful to explaining the concept to the parents. Remembering that just because you're both a couple does not automatically mean you will have an affected pregnancy. In fact, there's a 1 in 4 chance of having an affected pregnancy, but a 3 in 4 chance that the child will either be a carrier or unaffected. So what sort of results will you get from screening? You'll either get an increased chance result, and this means that one parent carries an X-linked condition, i.e. the woman, or both parents carry the same recessive condition. For X-linked conditions, yes, they have a chance of having an affected child, but it will depend on the condition itself. And that's where sometimes it's very useful to be able to speak to a genetics counsellor just to sort of iron out the nitty-gritties. And Fragile X is a prime example of this, where it will really depend on whether the woman is a pre-mutation carrier or has the full mutation, or indeed has a mutation in the grey zone. The one result I do find trips people up is the low chance result, because some people take low chance to mean no chance, which is not the case. Yes, the test didn't identify an X-linked condition in the parent, or the parent was found not to be a carrier for the condition tested for, but there is still a small residual chance of having a child that could be affected by the condition screened for. It really depends on the test you have chosen and the panel that test has for that particular gene, as I will show you on the next slide. And for this reason, it becomes really important to remember that if there is a family history of the condition, it's really important we check with the lab that they will be able to test for the family variant of importance in that family. In other conditions, there's still a residual risk. So for example, in spinal muscular atrophy, 2% of cases of spinal muscular atrophy in children are due to a de novo deletion on one of those alleles. So sometimes it's important to remember, yes, low chance, which means very, very unlikely, but it's not a 0 chance. You'd think that ordering a 3-gene panel test is exactly the same, but if we just look at the collection centres and the providers within the ACT, you can actually see there's variations in the number of variants, for example, in the CFTR gene that are screened for. And clearly, the more variants that are tested for, the better your chance of detecting a CF carrier. Likewise, only 2 of the providers offer screening for AGG interruption analysis, which becomes important when you've got a woman with a positive result for Fragile X and you're trying to identify the stability of her mutation and the likelihood of having a an affected baby. So I think it's important just to realise that all the tests are not the same. And that's also true of the expanded panel screening options. And on here, you can see that the number of genes and the costs vary wildly from provider to provider. And that may be based on the cost of the test, it may be based on the number of genes you can screen for, or indeed the sample type that will be affected. Some parents do actually find difficulty in wanting to sort of convey information to family, and it's important to remind them that if they're found to be a carrier, it's also likely that their siblings and extended relatives may also be a carrier. And the reason for encouraging them to share that information is really not for other family members' own health, but it becomes important when they're contemplating having children of their own. The final word I really want to say on reproductive carrier screening is, does this mean I don't need to be tested again? Well, it really depends on what testing they've had and why they're sort of wanting more testing. So if somebody's had a 3-gene panel, they of course have the option to have expanded panel testing. It may be somebody's had a 500-gene panel and wants a larger panel testing. I think we just need to be mindful as to why they're wanting the testing. And really, if in doubt for any of these things, what I would say is phone your friendly genetic counsellor. Okay, moving on to screening for early onset preeclampsia. So all pregnant women should be assessed in early pregnancy for their risk of developing early onset preeclampsia. And risk stratification can be done in one of two ways. Either history-based screening, and I will tell you more about that in a second, or what is becoming more available, combined first trimester screening for preeclampsia. If we think about screening based on history, we're really using a combination of maternal pregnancy characteristics, her own characteristics, and pre-existing medical conditions. This is a list that is available and has been published by SOMANS, and effectively you're saying that a woman is high risk for developing early onset preeclampsia if she has one or more of the high risk factors, which is in the top half of the box on the left-hand side of your screen, or she has 2 or more moderate risk factors. And if a woman is screened as being high risk for preeclampsia on the basis of 1 high risk factor or 2 or more moderate risk factors, we advise her to take 150 milligrams of aspirin every night, hopefully commencing prior to 16 weeks and carrying through until 36 weeks. Whilst this is a cheap, easy way of doing the test, the reality is you're only identifying 40% of pregnancies at high risk for preterm preeclampsia, and the test is as good as useless when you're looking for late onset preeclampsia. What's new on the market is combined first trimester screening. So basically, we're still using history in the form of maternal factors. We're also looking at mean arterial blood pressure. We're using an ultrasound marker in the first trimester of a uterine artery Doppler, and we're using a biomarker, either PLGF or PAP-A. And when you use that combination together, you can actually find your detection rate of preterm preeclampsia improves from 40% to 90% for preterm preeclampsia before 32 weeks, 75% for preterm preeclampsia before 37 weeks, and it's not very good at term. We use a cutoff of 1 in 100 to say somebody is high risk. And if, as before, if you identify a woman who is high risk, aspirin 150 milligrams every night until 36 weeks is indicated by way of prevention. Unfortunately, it's still not widely available across Australia, but there are a few radiology practices within the ACT who do offer screening. In this cohort who have screened positive, If the woman takes aspirin, we can markedly reduce her chance of developing preeclampsia. So we can see that the group who screen positive before 32 weeks, you're reducing their risk by 89%, and the chance of developing preterm preeclampsia before 37 weeks by over 60%. It's important to remember that a proportion of high-risk women will still develop preeclampsia despite the use of aspirin, and therefore all women who screen high risk should be educated about the signs and symptoms of preeclampsia. It's important we have respectful, compassionate discussions with our parents, explaining the purpose of screening, explaining their screening results to them, but also explaining the importance of aspirin and recognizing that aspirin will only work if it is taken. And if the woman misses as few as 10% of her doses, you will not get the risk reduction that has been seen in trials. And therefore, it's really important that compliance is reassessed every review. Aspirin is not totally a benign drug, but we certainly find women who can see their results as being high risk are much more motivated to take the medication. I'd also be remiss of not reminding you that if you screen high risk for preterm preeclampsia, that also means you will need level 2 fetal growth surveillance, which means additional growth scans at 28 and 36 weeks. In terms of aspirin, there is a patient information leaflet that can be readily obtained from the SOMAN's website. And this is the fetal growth restriction care pathway, which I'm sure many of you are familiar with. Those women who screen positive on level 2 in terms of a risk assessment, their additional scans are recommended to be done at an external provider. That's also true for a number of the level 3 scans, but many of those women will automatically also be high risk and involved in obstetric care. Okay, moving on to preterm birth screening. And here we're really thinking about the onset of spontaneous preterm birth. We know preterm birth is the leading cause of neonatal morbidity and mortality worldwide. We're talking about birth before 37 weeks. And in Australia, there are over 24,000 babies born preterm each year. And the preterm birth rate in the ACT at 9% is a little bit higher than the national average. All pregnant women should be assessed in early pregnancy for the risk of preterm birth and stratified either into low, intermediate, or high risk surveillance pathways. We mustn't forget to also think about other modifiable risk factors, so for example, substance use and smoking, and reminding them of the importance of promoting smoking cessation and making sure their pregnancy is smoke-free. But also we shouldn't forget the importance of continuity of care provider, especially socially disadvantaged and vulnerable women, and also thinking about urogenital infection screening. So, who is our low-risk population? Our low-risk population is that woman who has no history of spontaneous preterm birth and no identifiable risk factors. All of these women should be offered a transabdominal cervical length assessment as part of her morphology scan. And in fact, it's now standard practice across all ACT radiology services that they will perform this scan. If the measurement is more than 35 millimeters, that is normal, and that woman carries on with routine antenatal care. If on scan that measurement is 35 millimeters or less, or the cervix has not been well visualized, they should automatically proceed to performing a transvaginal cervical length scan. And I sometimes find just reminding the woman of what happens at the morphology scan so it doesn't come as a shock is helpful. If your measurement is more than 25 millimeters, all well and good. She remains low risk. She continues on routine antenatal care. If unexpectedly the cervix is super short or the cervix is found to be open, please contact us at the hospital. We need to have a careful consideration as to whether that woman would benefit from a cervical cerclage. If it falls between the 24 to 10 millimeters and even the less than 10 millimeters, please refer them through to the preterm birth prevention clinic. Prescribe vaginal progesterone for them, and that's a dose of 200 milligrams at night, which is to commence as soon as possible and continue through until 36 weeks. Obviously, remind them about the signs and symptoms of preterm birth and encourage them to present early if any of those occur. Think about smoking as a modifiable risk factor. And then these women through the clinic will have repeat cervical length assessments, often every 2 weeks, sometimes every 7 days, depending on the scan findings, up until 24 weeks. All right, let's think about women with intermediate risk factors, and this is where I think there's probably some new practice updates. You'll be very familiar that women who have had a significant cervical excision event form part of the intermediate group. The group you may be less familiar with are those women who've had a previous birth by caesarean section, and that caesarean section was performed at full dilatation. That group of women have a slightly higher than expected chance of having a spontaneous preterm birth in their next pregnancy. You'd expect a rate of about 1%, and it falls somewhere in the order of about 5 to 6%. Unfortunately, we don't know how to manage this group. It is becoming more of a challenging area, and if the woman has unfortunately experienced a preterm birth, it's very likely to keep happening in future pregnancies. So how do we manage the intermediate group? So the intermediate group require a transvaginal cervical length ultrasound at 16 weeks in the first instance, and that needs to be done at an external imaging provider, but please write the words transvaginal. If their measurement is more than 25 millimeters, that measurement needs to be repeated at the morphology scan, and again, it needs to be a transvaginal measurement. The final time this woman would get screened or is recommended to be screened is between 22 to 24 weeks, and then she can go back to routine antenatal care if the measurement has remained beyond 25 millimeters. The advice on the earlier or the lower measurements is as before. Finally, the high-risk group are really the ones that you want to refer in to the preterm birth prevention clinic early as possible in their pregnancy. So we're talking about women who've experienced a pregnancy loss between 16 to 24 weeks, not associated with placental dysfunction or a fetal abnormality, who've experienced a spontaneous preterm birth between 24 to 34 weeks. But we've also got women with certain uterine anomalies, if they've maybe got Asherman's syndrome, or indeed if they've got a transabdominal cervical cerclage in situ. I include this algorithm really for completeness, but effectively a lot of these women will have individualized management plans, and that management plan will be made in conjunction with them through the preterm birth clinic. I often get asked, how do we prescribe progesterone? So here is a quick slide on that. You can only use the streamline authority code for preterm birth, where there isn't a streamline authority code for recurrent miscarriage. That has to be a private prescription. But you can order a box of 42 with 3 repeats, and that roughly comes out at a cost of $32 per box, and each box will last the woman 6 weeks. Okay, moving rapidly on to syphilis testing in pregnancy, where again there has been a new practice update. So Australia is experiencing a syphilis endemic, and really since 2015, notifications of infectious syphilis amongst both First Nations women and men and non-Indigenous people have been increasing. And this has increased in major cities and outside of those previously declared breakout regions. Amongst women in whom we know the pregnancy status, 20% were pregnant at the time of diagnosis. And coinciding with this has been a concerning rise in congenital notifications of syphilis. If you look on the table on the right-hand side, you can see those notifications and you can realize that the vast majority of notifications are late diagnosis notifications. Amongst these cases, you have had cases that have occurred following a negative first trimester test, which is typically how we have screened the syphilis in the past, and because either additional risk-based testing beyond the first trimester didn't occur, or the pregnant woman had no identifiable risk factors. Mother-to-child transmission of syphilis tends to occur in utero rather than intrapartum, although it can happen if a woman has got a syphilitic lesion at the time of her pregnancy, at the time of her delivery. It can occur at any stage of pregnancy, but becomes more of an issue as she becomes more pregnant, and at any stage of syphilis infection. Remember, syphilis serology doesn't tell you stage of infection. And if in pregnancy the syphilis is untreated, there is a really high rate of stillbirth and prematurity and congenital syphilis in the remainder. And for syphilis, we have a safe treatment available. So what are the practice changes? So the practice changes you need to be aware of is that there is now a recommendation for universal testing during each trimester of pregnancy. So firstly, at confirmation of pregnancy or the first antenatal appointment, as we have been doing. A second test between 26 to 28 weeks to coincide with routine mid-trimester pathology. And finally, at 36 weeks or birth, whichever is earlier. It's also important that we constantly check and review the results to make sure we are not missing any positive cases. We still have an opportunity to opportunistically screen for syphilis if a pregnant person presents with signs and symptoms of syphilis, if she has symptoms of another sexually transmitted infection, she presents as a contact, or indeed she has experienced late, limited or no antenatal care, in which case please perform the other recommended pregnancy investigations and refer them on for pregnancy care. I'd like to just remind you of what a rash of secondary syphilis looks like. And if you look at the rash on the left-hand side, many people will not necessarily think of secondary syphilis as one of the differential diagnoses. And you can certainly find more information on testing, symptomatology and treatment in the Australian STI management guidelines. Interpretation of syphilis serology can be complex, and what I would say is it's best to speak to a specialist who has expertise in diagnosing and managing syphilis in order to make sure the woman is getting optimal care and the baby gets appropriately followed up, because part of the new guidance is also about what happens at the time of birth. But because of the audience I'm presenting to tonight, I am not including that in this presentation. In terms of infectious diseases, I will also just remind you that previously chlamydia and gonorrhea screening was recommended for women younger than 25 years. That has now increased to 30 years because likewise we're also seeing an increase in chlamydia and gonorrhea notifications in Australia. Moving swiftly on to another hot topic, which is measles. So typically, measles will present with fever, malaise, a cough, those typical Koplik spots on the buccal mucosa, followed by a characteristic maculopapular rash after those other initial symptoms have happened. That rash starts on the face, behind the ears and neck, and then spreads downwards. The reason I'm talking about measles is we are one of the countries which is experiencing an outbreak of measles, and it is a highly contagious respiratory illness with around 90% susceptible individuals becoming infected. The incubation period from exposure to fever is about 7 to 10 days, and the rash normally appears about 14 days after being exposed. A person is infectious from 7 days before to 7 days after the onset of rash. The one thing I do want to point out to you is unvaccinated pregnant women may present atypically with fever and abnormal liver enzyme tests being the only clinical finding of measles. The other thing that can be challenging is in women of darker skin, where actually the rash can be really quite hard to spot. Severe complications of measles are commonplace anyway, but pregnant women in particular are susceptible to needing hospitalization and developing pneumonia and even sadly dying. But hand in hand, because of the viremia, there's an increased chance of miscarriage, stillbirth, and preterm birth. There is no specific treatment, and it's about supportive care. In terms of measles exposure, I just want to bring you information that's hot off the press. So if you've got pregnant and non-pregnant people without confirmed immunity, they should be offered post-exposure prophylaxis. So a pregnant woman who's not received the MMR vaccine, which you can't give in pregnancy, should receive normal human immunoglobulin within 6 days of exposure. Pregnant women, postpartum women should receive the MMR vaccine within 3 days of exposure. And moving very swiftly on to vaccines. On this table, you can see all the vaccines that are recommended in pregnancy, plus the 2 I get the most phone calls about. So influenza is recommended at any stage in pregnancy and in each pregnancy. And if a woman has had a previous year's vaccination, it is advised that she gets revaccinated with the current seasonal flu vaccine later in her pregnancy if it becomes available. You're all familiar with the recommendation to vaccinate in every pregnancy with whooping cough between 20 to 32 weeks. And the new vaccine on the box is really the RSV vaccine, which currently is recommended as a single dose in only 1 pregnancy. We're still waiting to see what the advice will be about subsequent dosing in future pregnancies between 28 to 36 weeks gestation. I've included in blue on the chart, merely for reference, what happens if you've got susceptible pregnant women exposed to either measles as a reminder or chickenpox, and what post-exposure immunization is required. In terms of RSV, I don't need to remind the audience that it's a common virus and that it's spread throughout the year, but most commonly in autumn and winter. And it's babies who are under 6 months of age who have the highest risk of becoming sick and developing complications. With the Abrysvo vaccination, we can reduce the risk of hospitalization by 50% in the first 6 months of life. And as far as the woman is concerned, in terms of side effects, the main side effects they report is one of injection site pain, headaches, myalgia, and fatigue. And usually these resolve within 2 to 3 days after their onset. Just in case you've not seen it, it is a vaccine that needs to be constituted, that comes as a dry powder with a solvent, and it's very easy to reconstitute. If you want an information leaflet to give your patients, you can find one on the National Immunisation Programme website, but this one's actually quite nice from New South Wales Health and asks many of the questions women ask frequently about how it works, whether family members need to be vaccinated, and the answer of which is no. And on this next slide, I've also included a few other questions that I found I've been asked. And it's really about things like inadvertent vaccination before 28 weeks. They don't need to be revaccinated. Remember, the TGA has licensed the vaccine from 24 weeks, but the reason we're not vaccinating down to that lower gestation is really because of a signal control in the trial of a slight increase in preterm birth rates, which was about 1%, and we're still waiting for more information and data to become available to see if those gestational age cutoffs change. If they've had an RSV infection in pregnancy, it is still strongly recommended that they get vaccinated, because you can't rely on the strength of antibodies formed just from exposure to the RSV infection. And finally, last word on vaccination, if you actually want access to websites, the Sky website's actually very helpful if you want to be able to have supported conversations with these women. And in the last couple of minutes, I'm finally just going to, on a whistle-stop tour, tell you about the new or updated reminders about cervical screening in relation to pregnancy. So remember, routine antenatal and postpartum care is an opportunistic time in a woman's journey where we can actually review her cervical screen history with her. And it really is a good opportunity to reach out to those women who may have not had screening, may be due or overdue. So it's really important we ask about screening and we promote cervical screening and remind them that cervical screening is safe at all times in a pregnancy. We should give them the option of testing. And here I'm not talking about women who have symptoms suggestive of cervical cancer or those women who need a follow-up diagnostic test. They would follow a different screening pathway. I'm talking about the woman who's never been tested, who's overdue, whose previous pap smears have been normal. And really here we have an option. She can either do self-collection with a dry vaginal swab to look for HPV, or she can opt for you to do a cervical sample with a speculum examination, just like you have done previously. Both are equally accurate in detecting HPV, and the only thing we need to remind the woman is if her self-collected swab comes back detecting HPV, she will get invited back for either for us to collect a liquid-based cytology sample if she screens positive for HPV non-16 or 18, or referred on for colposcopy. It is very important, though, in pregnancy you use the right sampling equipment. So please use the cervical sampler broom so as not to unnecessarily cause some bleeding by using the endocervical brush and therefore causing unnecessary distress to the woman. Just a quick reminder on results management. If she's HPV negative, she comes back for screening in 5 years' time and she can opt for self-collection again. If she's got HPV 16-18, she needs to be referred for colposcopy regardless of her liquid-based cytology result. And in fact, that test can be obtained at the time of colposcopy. If she's got HPV non-16-18, she does need to return for liquid-based cytology, ideally within 6 weeks, but realistically as soon as is practically possible. The chart on the right-hand side gives you an idea of how often you're going to detect non-16-18 by age group. And likewise, if they've got a no abnormality or a low-grade lesion, it's recommended they have repeat testing in 12 months. Otherwise, they should be referred on for colposcopy. Colposcopy is safe, and really what you are doing colposcopy for is to exclude the presence of invasive cancer. Often you don't need to take a biopsy unless invasive disease is suspected, and sometimes it may be safe and appropriate to defer definitive treatment until after pregnancy, but obviously we then need to make sure they do return for follow-up. Some women choose to not have screening in pregnancy and defer everything until after they've had their baby, or sometimes they weren't offered screening. In which case, again, please use your 6-week postnatal check as an opportunistic opportunity to offer screening. You can test for HPV at any time, but if you're planning on using liquid-based cytology, it's preferable to wait for 3 months postpartum, but you'll need to make a judgment call as to whether you think the woman will return for screening or whether it's best to take the chance and do the test and avoid further delays. There is literature available for the woman on how to take her own sample. There's literature available in a number of languages, and there's also literature that can be specific for First Nations women. And my very final slide is just to remind you, if you need to check an individual's screening history, I'm sure you're all very familiar, you can obtain that through the National Screening Register. And with that, I thank you for your attention, and I'm going to hand over to Philip.
Okay, thanks, Farah, and welcome everyone this evening. I'm going to do a quick run through hemolytic diseases of fetus and newborn, and talk about how we're going to, from now on, really screen for RHD women in pregnancy to look at see if we can streamline our processes for anti-D administration. So just quickly to remind, really fundamentally, red cells, like all other cells, have antigens on their surface, and if we get exposed to other people's red cells, then we can develop antibodies to them, and we develop tolerance to our own self-antigens. So we can see this either through pregnancy or through transfusions to be exposed to those red cells. There are over 400 different red cell antigens that have been described, and these are due to antigenic polymorphisms and a whole variety of different genes. Although we most commonly think about ABO and then RHD as our most commonly thought of systems, there are in fact many of them. ABO and rhesus are the most common ones, but then we have KEL, Duffy, KID, MNS as being the most clinically significant. And they have a variety of functions, and blood bankers like to think about the functions of these proteins on the surface of cells that have structural roles. They might be receptors and transport proteins. RHD, or the whole rhesus protein, is probably related to transport of bicarbonate or something similar. It's actually not completely understood, but in fact it doesn't really matter. What matters is these are antigens, and that we can form antibodies to them if we get exposed to them when we don't have those particular proteins ourselves. This is different, a little bit different with ABO, where we consider these to be naturally occurring antibodies. The same sort of principles do apply, except the difference here is that these are large glycosaminoglycans, and we have very similar molecules present on bacteria. And so all of us will have, if we a group B, for example, will develop anti-A. For group O, will develop A and B because we are constantly exposed to those sort of antigens through our environment. And these are mostly IgM, and being IgM means that they don't readily cross the placenta very much, so their impact in pregnancy is a bit less. And so that's the sort of pattern we see. We tend to see that people who have A anti-B and so on. So apart from the ABO, all the other blood groups mostly are fairly similar in the way they work. We have to be exposed to the red cells in some shape or form in order for us to develop antibodies to them. There are some slight variations, but mostly that's the case. So rhesus is the most common and that we think about, and the reason we think about it is because it's the most antigenic, and consequently leads to the most problems in humans. We mostly think about D, again, because that is the most antigenic, but little c is highly antigenic, big E to some extent, all of them reasonably antigenic, and so they're all potentially targets. I'm going to talk about the RHD in particular. As you can see, these are just a number of variants that we have. So the RHD gene is on chromosome 1, and there are a variety of exons. Of course, these are the bits of the gene that get translated into proteins. Most of us will have a sort of of standard RHD gene. But for Caucasians in particular, there is a frequent deletion of the RHD gene. And that's what leads to people being RHD negative. You can have the RHD gene deleted. In fact, almost everyone has the RHD gene deleted while still having the RHCE component still present. They are inherited as a block, but there are different components to that block. So they tend to run together in groups, but so that second one down is a common Caucasian variant. There are other RHD negative variants, and in particular, there's a pseudo-RHD, which you'll see as a fourth one down there, which is a more common variant leading to RHD negative states in Africans. And what that means is that the genetic testing that you might need might be different to detect an RHD negative state in someone, or RHD positive state for that matter, in someone of African or Caucasian background. And then there are other variants, and the one here I've put in particular is the D6, because this looks most of the time like they're RHD negative. But if you use some sera in the laboratory, you occasionally find them being RHD positive. So occasionally we find people where with one set of sera that we use, we'll find them to be RHD negative, and with another set of sera, we find them to be RHD positive. And we call these partial Ds. And the problem is that some of these, particularly the RHD6, can cause someone who gets exposed to it to develop anti-D, and whereas others tend not to. Now, just to make life more difficult, this is a sort of larger version of what it might look like in terms of the many different variants we have in RHD that lead to types. And this is still a summary version. And I'll come back to why I put that up in a little while. It's important to remember that red cell antibodies don't cause harm at all unless you get exposed to the red cells again. So the problems we see with red cell antibodies are the development of acute hemolytic transfusion reactions, a delayed hemolytic transfusion reaction, or hemolytic disease of the newborn. And that's what I'm going to talk about primarily from here. So if you have preformed antibodies, they can cause harm by crossing the placenta and getting into the fetal blood. So it's usually IgG. So what that means, as I'm sure you know, that when we get exposed to a red cell initially for the first time, if we develop an antibody, it's going to be a lower affinity antibody, and it's going to start off being IgM. So a low affinity IgM is unlikely to cause problems in the current pregnancy. So it's usually what we're trying to do is prevent problems by preventing anti-D formation or preventing problems in subsequent pregnancy. But if that does happen, then you can develop hemolysis, which leads to an anemia. We can measure this by ultrasound, watching blood flow and comparing that to normal. And postnatally, you can develop hyperbilirubinemia, kernicterus requiring phototherapy, or potentially intrauterine or postpartum transfusions, or even exchange transfusions. So just to go through it again, there's some slides that one of my associates in the Australian Museum of Blood Transfusion put together. The mother has RHD negative red cells, and if her baby's RHD positive, then those cells can cross from the baby into the mother. Mother then develops antibody, which you can see here presented in the typical way as a little Y shape. And so the mother has antibodies. And then in subsequent pregnancies, the antibodies can cross the placenta to the next baby if they also happen to be RHD positive, and that can cause hemolytic disease of the fetus and newborn. So despite our prophylaxis program, which I'm sure you're all aware of, where we're giving anti-D to women during pregnancy and postpartum if the baby is RHD positive, this is actually still the most common cause of hemolytic disease of the newborn in Australia. and in most places where prophylaxis is given. It would be anticipated around Australia. In fact, these are the stats when the program was implemented, which is over 20 years ago now, for the intrapartum prophylaxis. It was predicted that around 78 cases of hemolytic disease of the newborn deaths would occur in Australia per year without that prophylaxis, plus an additional 55 babies would be born with hemolytic disease of the newborn that would lead to permanent disability throughout their life. So the program is impressive in that it's a preventative program that saves lives and long-term disability, and for that reason it's actually quite cost effective, despite the fact we're giving a program to a product to many people. So currently all women who are RHD negative in Australia receive RHD immunoglobulin prophylaxis. This is usually given at 28 and 32 weeks. And we also give it following sensitising events where we expect there's a possibility of those red cells in the fetus to cross into the mother. Now that can still happen anyway, even without a known sensitising event, and that's why we give the prophylaxis at 28 and 32 weeks. It's important to note, just because of the statistics, in a Caucasian population, that around 40% of RHD women will have an RHD negative baby, and that means they don't actually benefit from this prophylaxis during pregnancy in the antenatal period. Postnatally, we can detect whether the baby is RHD positive or negative before deciding whether to give the postnatal dose. So treatment, we've talked about a little bit. It's a phototherapy or intrarenal transfusion or exchange transfusion, and particularly, well, apart from phototherapy, I guess, is done relatively frequently, but the others clearly quite invasive procedures and carry risks to the baby. So to get around that, to avoid the initial development of anti-D, for women who don't have an anti-D present in their blood detected prior to dosing at 28 weeks, we give a small dose of anti-D that's derived from donors, and that then binds onto the red cells, and it does not cause hemolysis in the baby, or does cause significant changes. Nothing we can detect despite looking for it, and that leads to the clearance of the fetal red cells from the maternal plasma, from maternal blood, before they're causing any problems or ability to develop antibodies. So the mother then can go through the pregnancy without having developed anti-D and preventing harm in subsequent pregnancies. So the postpartum dose is actually the most important one in this process. When you look at it, when Australia first implemented prophylaxis, we did it initially post-delivery, and that's a long time ago now. And these are impressive studies. If you look at before it was implemented, 6 randomised control trials with over 10,000 women, with a relative risk of 0.04% of RHD immunisation. So that's an impressive p-value and effect, I'm sure you'd agree, and leads to a significant reduction in the burden of disease in Australia. The history behind it in Australia is actually really interesting. One of the earlier drivers was actually a woman who lost many of her pregnancies, and she became one of Australia's first anti-D donors, so that other women wouldn't have to go through what she went through. And it's also worthwhile acknowledging that very recently one of Lifeblood's very long-term donors, a gentleman known as the man with the golden arm, who is attributed as saving hundreds of lives because he was such a common and high titer anti-D donor that at one point he was probably accounting for up to 40% of the anti-D supply in the country, which is truly amazing when you think about it. Losing people like that from that donor pool, we got down to as few as I think about 109 donors propping up, and Red Cross has gone back and started immunising more people. RHD negative males in order to be able to get enough anti-D to be made in Australia. It's a really important strategy to catch women. Those sensitising events we talk about include miscarriage, termination, ectopic pregnancies, invasive diagnostic procedures, external cephalic version, which of course is usually done late in pregnancy and here, but abdominal trauma and antepartum hemorrhage are also considered. And after the first trimester, it's generally recommended that you also try to measure how much of that bleed there is, which we can do by assessing fetal maternal hemorrhage in the lab. So just a quick note on ABO, HDN. Why is it not more common? And really it's because two things. Firstly, those ABO antibodies are largely at IgM, and therefore they don't cross the placenta. They're too big. A simple exclusion mechanism. But we do see ABO antibodies in the baby, but their antigens are also less well developed. And so it tends to be less of a problem. ABO HDN does occur, it's just usually less severe and less common than we'd expect based on the ABO frequencies because of those reasons. So non-invasive prenatal testing, and Farah's talked a little bit about genetic screening of parents. Non-invasive prenatal screening uses the same sort of techniques, looking at PCR, but in this case we're looking at the DNA from the baby that's in the maternal serum. So that's actually relatively reliable after around 11 to 15 weeks. It just depends on how the assays have been validated and as to how low we can go with that. So many women are currently choosing to have non-invasive prenatal testing, such as the Harmony testing, which looks for genetic abnormalities in the baby early on, and that's usually done at around 10 or 11 weeks. But this is a different test that is really designed just to see whether the baby is RHD positive or negative, to decide whether a woman really needs anti-D. So very simple, you get a maternal blood sample, you send it for processing, and we look at the DNA, bearing in mind that the maternal blood will have both fetal DNA as well as maternal DNA. And when we PCR DNA, we actually can't tell the difference between those two. So if we detect the RHD gene in an RHD positive woman, that's sort of what we'd expect. So we can only really do this in RHD negative women, and we only really need to do it in RHD negative women. There's no point doing it in RHD positive women. So it can be done from around 11 to 12 weeks gestation and determine the need for prophylaxis. I guess our preference would be to do it earlier, so that if you do have a sensitizing event, that you know whether a woman needs prophylaxis for that or not. But just because of the limitations we currently have, we're recommending it a little bit later. It's currently being used internationally, including some Northern European countries. Canada is about to implement. New Zealand's worked up an assay and is almost ready to go, and the UK has been doing it. It has become Medicare funded. It's actually a couple of years ago now, but when they worked out the rebate, they were not attractive to anyone. In fact, there was a commercial assay that started getting therapeutic goods administration approval, and the manufacturer realised they would not sell it in Australia for the amount that the government was actually prepared to pay, and so they paused that process. So Red Cross Lifeblood can test women for who have preformed anti-D. There are actually two different tests that we are going to briefly talk about, because if you have a preformed anti-D, then the implications of missing that are significantly greater. So two things we can use RHD NIPT for. One is determine whether women should be offered prophylaxis. And in this situation where it's a low risk situation, we use a lower cost test with a high throughput assay, And we acknowledge that there may be a small amount of false results that enables widespread use. And the reason for those false results could be twofold. One is that with this insufficient fetal DNA in the sample, and unless we try to measure the fetal DNA, that can be difficult to know. And measuring fetal DNA is not easy, particularly if the baby is female, because if it's male, you can measure any Y chromosome associated gene to see whether there's fetal DNA. But otherwise, you have to look at genes that are differentially expressed in the fetus and why they're differentially expressed. And that comes down to epigenetics and methylation, which is quite difficult. Which is what brings us on to the second test. So if you have a woman who has already got anti-D and she's at risk in her current pregnancy, there is no margin for error. We can't afford to have that. And so there is a case here for having an in-depth study that's high cost, that does look to confirm the presence of fetal DNA, and that looks for multiple different places across the gene, so that we can be sure, no matter what the genetic background of the mother and father, we're able to detect whether the RHD gene is present or not, and whether that's going to have implications. That's very different to a screening test where we're just deciding whether to give antenatal prophylaxis or not. And there's a significant degree of difficulty between those two assays and margin for error. So the second one, for example, is repeated multiple times. And the only provider of that in Australia is Australian Red Cross Lifeblood, which they do under the deed of agreement with the Commonwealth and states and territories. So I'm going to talk more about this general assay for screening of RHD, because this is where the changes recently come. The other one has been around for a little while, and those women are usually managed in the fetal maternal medicine unit and have those testing done appropriately at the right time in pregnancy, so that we can identify whether they need monitoring or not during pregnancy and what intervention is required. For all other women who are RHD negative and don't have a preformed anti-D, then we do a test that usually involves only a limited number of exons, typically 1 or 2, and we do make sure the assay is worked. You have to make sure you get DNA product in your amplified PCR product, but it's not routine to look for fetal DNA. And so we can see these false negatives or occasionally false positives. Fortunately, they're few and far between, and the expectation based on the worst case scenario is we may expect to see at most 2 or 3 women in Australia who are sensitised because of an error in this test if there was 100% uptake. There are 2 different assays available in this side of the country. There is one that was set up in-house at King Eddie's in Western Australia, in Perth. They've only validated from 20 weeks because it's been done at a tertiary referral centre. And of course, we don't see women much before that for normal pregnancies. The 2 assays, one's been put forward by Lifeblood. Again, that's an in-house developed assay, but it does have TGA recommendation, and it's a very good test. Again, because of the limitation of getting hold of women earlier in pregnancy, they've only validated down to 15 weeks. Currently, there's one assay that's a commercial assay that's available in Australia that's been set up by Sonic Genetics. I think Helios, which is Lavity in this region, are also setting up the assay, but at the moment they're providing their assay through Lifeblood. They're sending samples to Lifeblood. So Sonic Genetics recommend that the test be done after 11 weeks, which is in accordance with the licensing of the assay that they've implemented. However, they recommend, if it is negative, that you do a confirmation test a second time if the woman is under 18 weeks. And so for simplicity, we're sort of recommending, after meeting with a group of midwives and obstetricians and GPs, that for most women, it's probably reasonable to defer that testing until they're able to get it done once and not have to worry about a repeat. And that's certainly going to be advice in the territory. For now, we're recommending we still check the baby's RHD status at birth. that gives us a bit of reassurance that our tests are working, particularly because we're new to the program, and would be offering anti-D if positive. But we're hoping not to see many or even any of those, and that's been the experience so far. So in terms of consenting for genetic testing, I think Farah touched upon before, is frequently fraught and difficult. And this is considered to be a very low risk test. Even though we're looking at a gene, what we're really aiming to do is find what the baby's red cell phenotype is for D, which we're going to find out when they're born anyway. So this is not telling us anything at all that we don't know about the mother. Potentially it's telling us something about the father, but not something we're going to find out that we would not otherwise find out when the baby is born. So when consenting women, we're not seeking written consent for this. It is low risk. It is important just to warn them that there is this very small chance that we can have a false positive or false negative. A false positive is not going to lead to anything more than them having routine care with anti-D prophylaxis. A false negative would mean they would not have that, and then potentially, there's a really small risk that they might develop anti-D. So for those high-risk pregnancies, it's important that they be referred on to get this more intensive testing done earlier. For the woman, it actually doesn't make any difference. It's just a blood test. But we do send it somewhere else. We send it to Lifeblood, and we do get the testing done in a very a sophisticated way. Important to note that we have it also available for KEL and KID antigens as well as anti-D, big C, little c, and little e. So that's this again. That genetic complexity is why we do that more complicated test in high-risk pregnancies. So I'm not going to test you on this, but this is a pathway that the Australian New Zealand Society of Blood Transfusion put together with a collaborative group around Australia. This included, again, midwives, GPs, obstetricians, and people with a transfusion interest and people with a molecular interest in the area. And we put forward recommendations about what to do. These look complicated, but in fact, it's quite easy to follow through to see exactly what you need to do. And I think for most RHD negative women, it's important just to offer them a test and then to decide whether they need RHD a prophylaxis or not later. And we've tried to standardise reporting across the country so that hopefully the answer will be pretty obvious when you get the pathology report back. So we talked briefly about other blood groups. We do have the ability to look for those in women who have been previously sensitised, and we do that. We strongly recommend early referral of those to the fetal maternal medicine unit so that we can undergo appropriate testing and surveillance and reassurance if it turns out that their baby is negative for one of these antigens that they carry an antibody to. It's important also to recognise that hemolytic disease of the fetus and newborn is a bit different depending on the epitopes that antibodies are directed against. KEL, for example, is quite a different beast, where babies get quite anemic and they're not actually hemolyzing because the KEL is expressed so early in the development of red cells. In fact, their bone marrow is quite devoid of many red cells, and the process so it looks quite different. And in this situation, KEL in the antenatal setting, those antibodies are not predictive of what's going to happen to the baby, whereas they tend to be quite predictive with rhesus, and not so much with that. I'm going to skip through that. So I've talked a little bit about that already. And just to acknowledge the people who are on the steering committee that put a lot of this together. If you want to know any more, we have a stack of resources on our website. You don't have to, they're free to get into. I think our website's just in the process of being updated, but you should still be able to get into them. And they're available there for anyone to use if you need any information. And I think, as Mel said, the local pathway will be updated, or is being updated, to incorporate this into the pregnancy pathways. And I'm happy to answer any questions.
Thanks, Phil. It looks like there's just one at the moment from Tracy, which is very similar to one that I remember asking in the working group meeting at one point. If there's someone, a pregnant patient, who's declining anti-D and they want their partner to be tested for their rhesus status, what are we doing about that with the non-paternity and how we broach that subject? I think either of you can answer this one if you want.
So can I just clarify the question? So if she doesn't want to have the NIPT because her partner is RHD negative?
So Tracy's asked about whether they're declining the anti-D. So I think it's the actual anti-D.
Oh, declining anti-D because their partners are RHD negative?
Or because they've requested. So Tracy might need to add a little bit more information here. But really, if their partner's being tested, and it's the non-paternity question again.
Yeah, okay. We try to avoid the non-paternity question by not asking it. I guess has been our approach in terms of screening. Obviously, the woman is the best person to know that. If there's no hesitation or question about the partner and the partner is RHD negative, then there is no need to have screening and testing. And I've certainly, I obviously don't advise women on this very often, but occasionally I've had the situation where I have become involved because of a variant D, when we're trying to sort that out, and have given that advice. And if women are very confident about who obviously the father is, then if we insist on testing, we're being a little bit paternalistic in some ways. Farah smiling.
Oh, I think you always just smile and you say, assuming paternity, of course, and they'll just smile and laugh and say yes, and that way you've got your message across, and they have a right to make an informed decision.
Yeah.
Although I think they're probably more likely to uptake the NIPT than they were to sort of necessarily have prophylactic anti-D. But it'll be interesting to see if the same question occurs with the new testing.
Just in terms of funding, Mel, I guess between us we did a bit of a ring around, and so there is a Medicare rebate for this. Irrespective of where you go, we feel confident that this is going to be Medicare billed, and there won't be a private copayment. That seems to be the message from the laboratories. And I think that's entirely appropriate because there are actually two reasons for doing this testing. One is to, of course, stop the woman having to have anti-D. And the other is to get a reduction in the amount of anti-D we need, which is really a public health issue. If we currently import immunoglobulin for other reasons. We do import high dose anti-D if we get someone who has a very large fetal maternal hemorrhage and give it intravenously. But we aim to be self-sufficient and should be. And that does mean getting normal donors who are RHD negative, giving them RHD positive red cells, and only a minority of them actually will develop anti-D in high enough titers to be able to become donors. So you have to actually round up a lot of usually men, because we don't want to do this to women who obviously can have children in the future. And younger men are good because they've got a lifetime of donating ahead while they're well.
There's been questions about the referral process. There is a link for the, or if you look at the resource library that I've put in from the Lifeblood website, you can find on there the PDF for the referral. we should probably talk about getting the blood test done, because there's a bit of difficulty with, or there's some nuance, maybe I should say nuance, around getting that done. So the blood test, if it's done through ACT pathology, it needs to go to Queensland to actually go through the assay, and there's a time restriction for it. If we're ordering it from the community, and this is what I realize I possibly haven't asked previously, are we using the lifeblood form to send the patient to ACT pathology with?
No, not necessarily. You can if you wish. Essentially, what we need to know is a woman's due date, because lifeblood won't do the test if it's done too early. And I guess from that, we need to work out what her current gestational age is, so that we can send that. It's also whether we have antibody screen results. I suspect lifeblood won't not do the test if it's we don't have antibody screen results, but clearly if there's a positive antibody, then we need to be looking at doing a different test. So the limitations on the test transport, that would also apply to most labs. So at the moment, Australian Clinical Labs and Lavity will be sending it to Lifeblood as well, and they'll have the same restrictions. The testing is a little bit different through Sonic, through Capital. They're going to send it to Melbourne. But again, it's not the sort of test, like with most genetic tests, if we're going to have to send them, we prefer not to get them on a Friday, so that they could be sent into state if need be, and the test or the DNA extracted if need be. And you can freeze it down after that if you're not going to run the test the next day, but they're usually done pretty quickly.
And we were talking in the meetings that we were having that ideally these blood tests are done Monday to Wednesday to make sure that they are actually getting to Queensland in the appropriate time frame for them to be able to manage them. That includes if ACT Path come and pick up from your practice. If you're collecting your own bloods, you can still do that and have it go through ACT Path, but you'd want to make sure it was in that pickup for the Wednesday afternoon, so that it was in the lab to be sent off on Thursday at the latest.
That's right.
Oh, looks like we've got a few more questions here coming through. So yeah, through Lifeblood, basically it's through ACT Path or through most of some of the other pathology providers apart from Capital, who are doing it in New South Wales, that they're doing the Sonic ones?
Sonic is done in Melbourne. They've got a national genetics laboratory. Sonic,
Tracy's asked, if we refer women to the public antenatal clinic, can we assume the test will be done if they are rhesus negative, as we rarely get communication back from the antenatal clinic? Yeah, so this is where we're also sort of linking this in with the work we're doing on shared care. So yes, if we're not seeing the patients, the idea is that this is being picked up by the midwives and or obstetricians, depending on who the patients are seeing in the public clinic, to be done with that 24 to 20, technically 24 to 28, we're saying 24 to 26 week bloods. Certainly in general practice, if you're seeing patients earlier and they want the test done closer to the 15 weeks, that is absolutely fine. We're just trying to keep it simplified so that we're not making people have an extra blood test when they don't want to, and they already have to go for the other ultrasound and all that sort of stuff. So that's all been about making it easier for the patient, but absolutely they can get it from that 15-week mark. Ideally, if we can copy in, as much as that's difficult, copy in the antenatal clinic or copy in the hospital, so they get a copy of the result as well, but it should be going up on the patient's My Health record anyway. Tara's asked when we can start ordering this. We can start ordering it now. This is available now. Anti-D, is Anti-D recommended in less than 12-week rhesus negative people who have spotting or threatened miscarriage, or only at a later gestation?
You want me to answer that? So
I'm happy to hand over.
At the moment, there's insufficient evidence to say that in threatened miscarriage before 12 weeks that we need to actually give these women anti-D, unless we think the bleeding is repetitive, very heavy and associated with sort of significant trauma or abdominal pain, in which case we would then give them some anti-D, assuming they haven't got preformed antibodies. Otherwise, no, we wouldn't before 12 weeks. And I think that along with that, whilst we're waiting for the NIPT result to come through, if a woman had a potentially sensitizing event, we would still give her anti-D until we knew the baby's rhesus D status.
Which we should probably point out the reason that we sort of are talking about those blood tests being slightly earlier at 24 to 26 rather than 26 to 28 is because it can take 10 to 14 days. Is that what it was to get a result back?
It's all pretty new, Mel, but the promise is 10 days from lifeblood. Yeah. So there's a bit of leeway in there. And hopefully over time, as the test gets done more frequently, there'll be increased runs and we'll see that turnaround time improve.
Yeah. But we just need to make sure that we've got that time frame before the anti-D would otherwise be due to be given if we were going to be otherwise giving it. And so I think we answered the question about getting it done earlier in the week. Yes, get it done Monday to Wednesday if we can. And so, yeah, you can send the patient to ACT Path with the lifeblood form. You could attach the lifeblood form to an ACT Path form, or just make sure on the ACT Path form you've got all of the relevant details. I've just been looking at the form, and it's pretty much all of the normal stuff. You just want to make sure that you've got that blood group and antibody screen details in there. Probably makes as much sense as anything to attach it. Does that, if especially?
Yeah, that's fine. And we've set up a process through ACT pathology. I can't speak for the other labs, but look, I know Sonic has a form themselves that basically replicates the lifeblood form. We don't really want to do that, but we do have, when women turn up for the testing, they will be, our collectors will try to ask all those questions. And most women know what their expected due date is. And so we'll probably get that. And then you can work out what the, their current gestational age is. And they may not know, obviously, whether they've got antibodies or not. That might be a bit foreign to most people, but we could probably live without that.
So probably if we're collecting them in our own practice, it would be worthwhile, like just attaching that blood group and antibody screen that we've already done earlier in pregnancy, just for ease of processing.
Yeah, that'd be fine. Yeah.
And so Tracy's just checking not to give anti-D for miscarriage. To give anti-D for miscarriage after 9 weeks, but not before. Yeah, we don't. We're certainly not giving anti-D for anything before 9 weeks. That's why for early medical abortion, we don't have to worry about anti-D for that these days. We used to, but now we don't. So nothing before 9 weeks needs anti-D.
But for miscarriage after that, before 12 weeks, it's the smaller dose, but not for just a little bit of bleeding.
And I think for the meantime, let's send the lifeblood form and the ACT Path form if you're collecting the blood yourself, just while we get processes nice and nailed down. No one wants to take a blood test to then find out that someone's rejecting it because there wasn't something answered somewhere. So let's be more thorough to begin with, and then we'll see once we're all used to it in terms of what questions we're asking and writing it on our own ACT Path forms.
If you're only sending in this test, if you're doing other tests, obviously it has to go on a different form. But if you're only sending in this test, then we don't need an ACT pathology form.
Okay.
Yeah, you can send it to us through with the lifeblood form, or whichever form, as long as it's got the information on it. So, I mean, I guess many people are going to be printing something out in their own practice. And, if you put in the history those things that are on the form, it'll save you having to worry about, doing everything in writing again, back to the that or these.
Excellent.
Speaking as someone who's not renowned for their readability of their writing.
We have come to time, and we seem to have answered all the questions. So thank you, Farah and Philip. It has been a great session. And if anyone comes up with any further questions, on the Eventbrite invitation, it had the email address to my office, which is OGPPC, which is Office of General Practice and Primary Care, at act.gov.au. Or you can send them to CHN and they can get them across to us as well. We can follow up any questions that you have after this as well. But thank you all and have a good rest of your evening.
Thanks, Mel.